And it is my great honor to be here to join this section. And as you see, the topic here we are emphasizing on the social and behavioral aspect. And I'll touch on what is the user perspective if you want to successfully for using ARV-based for HIV prevention. Outline of my talk, I will try to mention why user perspective is very important and crucial to the success of ARV-based HIV prevention strategy, and then what's the difference between HIV positive people and also HIV negative who have a high risk, and then what can be the barrier and motivator to the success, and then go to the conclusion. Since I myself also the site PI in Thailand to involve in HPDN 05 too, I play Olen also the rectal microbiocide MTN 017, so I think I have a chance to share some thoughts that we learned from the participants from all this time that I just mentioned. This is a diagram, and you can see you need to start from the top. To put the intervention, you need to increase HIV testing, and then if they not come to testing, you cannot do anything. If they come to the test, and then you have a test result. If they have the test result as HIV negative, then if they have a very high risk, and then they may be eligible for the PrEP, and then you may put them on the PrEP, and then also do the adherent counseling. If they become to be the HIV positive, then you do the post-test HIV positive counseling, do the positive prevention for them, and also try to link them to the care. And also, if they're eligible, then you can start the ART treatment. And this one will be vary by country, because most of the developing country now they said the CD4 allow 350 or below 500 before you starting the ART. Different from the US and Western country that they start ART regardless of the CD4. And then if you put them on the ART, you need to do the very good for the ART adherent to make sure that you can do they can go into the viral suppression by doing both for the PrEP, for the HIV post-negative high risk, and also treat the ART for the HIV positive. Hopefully, you can decrease the HIV transmission to the other people. This is so simple to the diagram that I just mentioned to you. We can make sure that it will be really work as we think or as we plan or not. Since we are the healthcare provider, we are the researcher, but as we know that the clinical trial, mostly we have the different environment really from when we want to do the implementation of the program in the real setting. This is all the strategy that we have for many decades. But anyhow, we have the oral PrEP, and also we have the treatment as prevention just come in the last few years. So how we incorporate the ARV-based for HIV prevention into the other behavioral intervention that we really learned from the past, include the condom use. For the user perspective, it will be very crucial if you want to success to control the epidemic. You always say safe sex practice, using condom, reduce number of the sex partner. I always say the doctor and nurse always easy to say to the participant, but it's not really easy to behave to adhere all the time. Taking a pill every day may be easy for someone, but mostly will be quite challenging for most of the people, and then they have their own reason to take it or not to take it. Either they're HIV positive or negative people. And most important, I would like to emphasize here, nobody can do it, this kind of thing. They need to do it appropriately and correctly by themselves. You can teach them how to use a condom, but they need to use it by themselves. No need to buy the banana, this one. You can show them this is a drug that you can take. It's easily just put into your mouth and for swallow with the water, but it's really easy to taking the drug as we think. We always saying that it should be good for them, for you, to prevent the HIV infection if you take the drug. But the people may be think and then they may act differently from what we thought. We always said wear condom is good. It can help you to protect to getting HIV from your sex partner. But they may think using condom, it may, with my sex partner, it means that I didn't trust on them, on my lover, and They may think I may have HIV positive in my body. So this is what we think differently from the user. We can see the condom use in some the survey. This is the survey from Cape Town. You can see the use of the condom is different. They may use more with the cultural sex partner, but anyhow, when they say use more, it's only 50% that they always use it. But with the regular partner, the use of the condom will be quite small. Taking a pill a day can help to reduce your chance to get HIV infection. But the user may think if I take it, then my partner may think I have HIV positive, or the user they may think I don't have any risk. Why I need the drug? In that case, we have the HIV positive. We have the HIV negative person who have engaged some risk behavior and then become to be HIV negative person. And this one I say is only one direction. Since you get infection, then you become to be HIV positive. Not as the other STI disease, when you get it, you can treat it and then you can cure and then you may get infected again. But for the HIV, it's only one way, from negative to positive. So why is important? User perspective will be different from HIV positive people who need to take a drug, and also from the high risk people that they may or may not take the drug. The benefit for HIV positive person, I can say here, the drug also good for themselves to treat the virus in their body. And we learn from HIV-05 that the drug not only for the treatment, but it can also help to prevent the transmission to the partner. But you need to emphasize here that it will be successful to prevent the transmission only if they take a drug very good and then they have come to the undetectable viral load in their body. And also they have some disadvantage for the people who are taking a drug because they need to take for the whole life. And if you take it very long, it may relate with some side effect or some comorbidity from the drug that you take. The people who have HIV positive, if they have very poor adherence or they're not ready to start the ART, then you can have a chance to induce the drug resistance, and then that can be passed to the other people. And taking the ART, many countries, many society can also induce a stigma and discrimination as well. Come to the HIV negative people, the benefit here, what we learned from the presentation of Professor Klim, we know that drug can help to prevent or to reduce the chance of HIV infection. I say reduce the chance because it's not 100% to protect them from HIV acquisition, but they will need to take it, as I say, daily. It no need to take for the lifelong, but when they should start to take the PrEP, and when they should stop, they will be very challenging because many times the people may be stopped before, and then since they still have engaged in some risk where they may get infection. If you heard from yesterday evening, the IPREC letter presented by Bob Grant, you will see the people who are put on the PrEP, at the beginning, the item is really very good, but you can see among the HIV positive happen because the antigen is being going down, and then at some point in time, the people who don't take it, then they'll get the HIV infection at that point. And also they have the disadvantage for the people, negative person who take the drug because it can cause some side effect to them from taking the pill. And also taking a drug, if they have an acute infection that time, that may be related to some drug resistance as well. And also the most important thing, the same as the HIV positive people, taking the ARV drug can be stigmatized and then can be stigma as they are the HIV positive people. We have one participant in the IPREC randomized control trial in the first phase. We have one participant who is a young gay man, HIV negative, and then join participate with the IPREC and then took a tour down. Few months later, after he involved in the trial, and his mom saw the drug in his pocket, and it's a big one, it's blue color, and then his mom is very clever, searching for the Google, and then, oh, this is a Truada, and Truada for HIV, for treat HIV, and then they have some problem happen after that. That's why this young gay man need to disclose to their mom that he's a gay man, and also he he took the drug, but he's not HIV positive, but he joined the clinical trial. So how good we are doing right now? We set the target 90% for people have access to HIV testing. We say 90% to people put on the treatment, and we also set the target 90% that we can achieve to suppress the virus in the body. All these things is very challenging for us. If you look this data, the most important for us, how to get the people know their HIV status. You look in data in the mini study, you can see most of studies saying around 30 to 50% of the HIV positive, they are unaware about their HIV status. And mostly because they are unaware of their HIV status, they provide a big proportion to transmit HIV into the other people. And also, late presentation can be the big issue. This data from the Thailand, you can see the 2008, that we started ART when they have the CD4 less than 200. 2013, we're going up to less than 500. But you can see the median for of the, then they initiate the ART is still quite low. Nearly 50% of the people, when they start ART, they have CD4 less than 100. So what does it mean? That means most of the people are not aware, and then they come to see the doctor when they have some signs and symptoms. So how can we do better than this? Even we say we set CD4, regardless of CD4 to start the ART, but if they come quite late, then it may not really help to stop the epidemic in your country or your community as well. And also the viral suppression is the key here, as you see from HPN-052. If you are not successful to control the virus in their body, then ARV-based prevention may be not really work efficiently. You can see the data here. The people who are on ART and the people who are suppressed, they really allow 50 to 70%. The same as in China, in UK maybe a little bit better. So all countries, you look at HIV cascade, and then you look at the last column to see how good they can do to suppress HIV. If you're not doing very good, then you lost a chance to stop transmission of HIV in the community. So the key here, I like to emphasize here, we need to understand more and more about the perspective of the people who are going to use it, either HIV positive or negative people, the key affected population, how much they think, understand, and be able to be a part of the goal. How much they know about the ART for prevention, for treatment. And then I like to say that the ARV drug do not replace the other HIV prevention method, either for the HIV positive people or HIV negative people who take the drug. And then a summary, I want to end this one. And if you want to success, and then we need to understand more and more, and then need to design the intervention to really fit to any specific target population, because they always think differently, even they are in the same group. The other issue will be presented by the following speaker, how to do it. Thank you.